This is a case of ictal-induced bradyarrhythmia as a rare but important cause of death in epileptics. Cardiac asystole accounts for 2 to 18% of epileptic deaths. As our case highlights, ictal-induced bradyarrhythmia, which occurs in less than 0.5% of patients with epilepsy, is a sequence with significant cardiovascular consequences. Our patient is a 60-year-old woman who had a history of complex partial seizures and was brought to the emergency room from her adult foster care facility after staff had witnessed seizure-like activity. She had a severe developmental delay, which is why she was living in the AFC. On arrival, she had returned to her baseline but became unresponsive, actually right as she was about to be discharged, and was found to be in cardiac arrest. After cardiopulmonary resuscitation was initiated, she had return of spontaneous circulation within 30 seconds and again returned to her baseline neurologic state. What's really interesting about this case is that it was just by chance that she had this event be witnessed in a hospital. Her medical history included this developmental disability, seizure disorder, that had previously been controlled on carbamazepine, diabetes, hyperlipidemia, and coronary artery disease. Her physical exam was quite benign. She was alert and resting comfortably in bed. In no acute distress, she actually sat up and said she was feeling much better pretty quickly after her cardiopulmonary resuscitation. Her heart and lung exams were normal, and her neurologic exam did not reveal anything concerning, such as gross focal motor deficits or cranial nerve deficits. Throughout her stay, she had a full cardiac workup with lots of imaging. She had a CT brain that showed no acute intracranial abnormality, a CT chest for pulmonary embolism to rule out PE, a transthoracic echo that showed no ventricular abnormalities or valvulopathy, a CT coronary which showed no significant coronary artery disease, a pharmacologic stress test that showed no evidence of ischemia, and while she was there, she also had an EEG to work up why her seizures were occurring when they had previously been controlled, and it just showed generalized slowing that was consistent with encephalopathy. If you look at figure 1, you will see the patient's rhythm strips from before, during, and after the cardiac event that occurred in the emergency room. Figure A shows normal sinus rhythm. Figures B and C show that the patient was having bradycardia prior to the cardiac arrest. Panel D shows asystole, and panel E shows return of spontaneous circulation after the CPR. Her clinical course throughout the hospital stay was quite benign. She was initially placed on telemetry and external pacing pads, and we continued her home regimen of carbamazepine and added topiramate on top of that to control the seizures. She remained at her baseline neurologic state throughout her stay, and there were no further seizure-like activities or cardiac events noted. We placed a permanent pacemaker and discharged her. Her presentation is consistent with ictal-induced cardiac bradyarrhythmia, which is one of multiple proposed mechanisms for sudden unexpected death in epilepsy. In this condition, it is proposed that patients first have a complex partial seizure, which is followed by tachycardia, and then bradycardia, and then asystole within 30 seconds of seizure onset. While sudden unexpected death in epilepsy is commonly associated with tonic-clonic seizures, cases of sudden unexpected death in epilepsy that involved post-ictal bradyarrhythmia are most commonly associated with partial seizures, such as in our patient. As we noticed while trying to develop a plan for our patient, there are very few recommendations available for patients with ictal-induced bradyarrhythmia. We did find one study that showed that if the bradyarrhythmia lasted for longer than 6 seconds, the patient would benefit from placement of a permanent pacemaker in order to prevent loss of postural tone and dangerous cardiovascular outcomes. While ictal-induced bradyarrhythmia is documented rarely, it is possible that it is a preceding event to cases of sudden unexpected death in epilepsy. As I mentioned before, it's just by chance that we were able to capture this sequence of bradycardia to asystole to return of spontaneous circulation. If she had been at home when this event occurred, we would not be able to attribute it to ictal-induced bradyarrhythmia. Further awareness and research into the treatment and prevention of this condition could make a significant difference in patients' lives.